Dr. Naresh Shanmugam. He's a consultant pediatric gastroenterologist and hepatologist from Dr. Rela Institute and Medical Center from Chennai. He's going to talk to us on congenital cholestatic syndromes in children. Over to you, Dr. Shanmugam.
Hi, a very good evening to you all. I'm glad that you remember me, though we haven't met for last 2 years. And I would like to thank the Sri Lankan Society for meeting you all during these times. Hopefully next year we will catch up. Uh, so I have been asked to talk about congenital cholestatic syndromes uh, in children. So essentially, if you are going to talk about congenital cholestasis in children, essentially uh, we are talking about uh, mainly infants and neonates. When they are children, mostly they will have a different form of disease. So my focus will be on neonates and infants with congenital cholestasis. And if you try to make a diagnosis of the congenital cholestasis, it's like trying to find a needle in the haystack. Uh, but in, I'm going to give a talk for the next 20 minutes, and definitely I'll make you see the needle in the haystack. Does this child has a problem? Anyone can tell that this child has a problem and it's grossly abnormal. So that's an easy job. But in reality, what we see is a child like this. Unless this is some a child that you would see in the outpatient department, and if you see deeply, you can find a tinge of jaundice in the eyes. Apart from it, a healthy child, easily these children would get missed in the outpatient department, and only when they become really sick they get picked up. So this is the problem what we face in reality. So going to congenital cholestasis, there are hundreds of conditions which can cause congenital cholestasis. Uh, but as a clinician, uh, do you really need to know all this condition? The answer is no. I think what you need to know is few conditions which I'm going to show, which will account for nearly 90% of the cases what you would see in your practice. I think the audience is mainly adult gastroenterologists, transplant surgeons, and pediatricians. So this would account for nearly 30%, 90% of the cases that you would see in your clinic. The first one is developmental, that includes biliary atresia, and that accounts nearly for 60% of neonatal cholestasis, what we see, and accounts for more than 50% of all transplantations. Then comes metabolic disorders, progressive familial intrahepatic cholestasis, galactosemia, thyroidemia. These are some of the common metabolic disease which we see in day-to-day practice in this part of country, in South India and Sri Lanka. And finally, infection. Unfortunately, this infection, cholestasis due to infection, has been overrated, and people put this one as the first differentials. Unfortunately, that's not true. Congenital infection causing cholestasis is quite rare, and we hardly come across them. So, what is the aim of the investigation? To identify the treatable cause, recognize complications, and yearly referral, whether it's going to be a medical management or surgical management. So let's go through a history. This is a very common scenario in a pediatric practice. Most of the newborn babies get jaundiced, they get phototherapy, and then they get discharged. So this child had a phototherapy between day 4 and day 6, and the jaundice was decreasing. This child is like 2 weeks now. The total bilirubin is 11 milligram, and the conjugated fraction is 0.9 milligram, and the enzymes, everything is normal. For a normal pediatrician, The initial bilirubin would have been something where like 18 or 19 before phototherapy, and it has come down, and this is a downgoing trend. So most of the pediatrician would be happy with this report. So this is a very common history what we see. Most babies has a physiological jaundice. When these children are having a physiological jaundice, can I predict a future trouble with this sort of investigation? The answer is yes. In the first 2 weeks of life, if the direct bilirubin is more than 0.8 mg per deciliter, or more than 8 to 10% of total, these children has high risk of developing liver disease. So these children should be followed up in the clinic. It can be biliary atresia, it can be something else, but when the conjugated fraction is more than 8 milligram per deciliter, because this is a very classical history saying that, oh, this my baby had a neonatal jaundice under phototherapy and discharge, down the line 3 months, child has biliary atresia. Moving on to these are all real-time scenarios. This is real cases in presented to our practice. So we have an infant who came for a routine vaccination. Child is absolutely well. Mild jaundice. When we do the bilirubin, the total was 7 conjugated fraction. So this child, the mother said to the pediatrician that the stools are pigmented. So the pediatrician did a torch panel and he found out that the CMV IgM is positive. So he was quite happy. So he started this child on valganciclovir and sent this child home. Is it a right decision? Because in the last 2 years, with the availability of CMV PCR and this antibody test, more and more pediatricians try to investigate these children with cholestasis, and they tend to do the torch panel, they tend to get a PCR done and start these children on ganciclovir. Unfortunately, mere presence of CMV in blood or urine is not diagnostic of CMV liver disease, and you need to have liver tissue PCR or an inclusion, CMV inclusion in the biopsy to tell it's CMV infection. This child had a biliary atresia and it was practically missed because the pediatrician thought it is CMV disease. Another child, 10 weeks old, mild icterus, mother says pigmented stool. What should you do? The first thing what you should do is don't believe what the parents say. See it for yourself. Because the understanding of a parent or even a junior intern is entirely different. So we use a stool card to check the color, and actually this stool card increases the sensitivity of picking up pale and pigmented stools from 72% to 91%. Even some apps are available. Uh, the key is see in person. And this child had biliary atresia. This is a quite common condition. More than 50% of neonatal cholestasis is due to biliary atresia, and they have high GGT, and if they have absent spleen or polyspleen, gives a clue towards biliary atresia. And so far we haven't got etiology so far. People implicate reovirus, rotavirus, and some immunological phenomena, but so far the real etiology is unknown. And it presents with the classic triad of jaundice, pale stool, and high colored urine presenting beyond 2 weeks of life. And it can be a early fetal type where the jaundice starts in first week of life and persists throughout, or there can be an initial normal period where the child can be jaundice free and then get jaundice after a month's time. So how do we diagnose biliary atresia? Biochemistry, the jaundice can be anything to anything, but what we look at is a high gamma GT, because low gamma GT points towards a different condition. You have to look at the stool color, obviously check with the chart. Ultrasound, it is not a gold standard test, but definitely it can give a clue. An absent gallbladder can give a hint. HIDA scan is no more in the picture, because if you see the stool and it's yellow color, HIDA scan is going to show excretory pattern. So it's a pointless test, so we wouldn't recommend it. MRI, again, it is not sensitive for arthritic duct, so not recommended. Biopsy, if you have a good histopathologist and if you could get the report within 24 hours, you can go for biopsy. If the child has the classic triad with high gamma GT, we directly go for perioperative cholangiogram and do the Kasai surgery. So in 1956, Professor Morayo Kasai did the first surgery where he connected a loop of intestine to the port. Or at least 50% of the children can do well. And what are the factors that affects the success of this Kasai portoenterostomy? Earlier, in clearing the jaundice, but as time goes by, it decreases. After 120 days, we wouldn't recommend Kasai as the success is practically zero. And even when we do the during the Kasai surgery, portal plate, if the portal plate ductules are larger than 150 micrometers, the success rate is quite high. These are two registries which shows nearly 50% to 40% to 50% of children at the end of 10 years can live with their own liver if they had a successful Kasai. So this is the reason why we recommend Kasai surgery and then go for liver transplantation. So biliary atresia, if you don't do a Kasai, you offer liver transplantation when they are 6-7 months of age. Usually that's the time these children will start decompensating, where you will start seeing ascites and all sort of complication at around 6-7 months of age. If you do Kasai portoenterostomy, 1/3 fails to clear jaundice and they need to go for a transplant. 2/3 of them clear jaundice, but most of them will develop complication. 1/3 of them, the jaundice recurs due to cholangitis and require transplant within 1 or 2 years' time. Some of them can develop other complications without cholestasis, like portal hypertension, failure to thrive, hepatopulmonary syndrome, requiring liver transplantation. So you can see this is a child with failed Kasai. It can be quite disturbing. So as I said, with the native liver survival of 40 to 50%, we still recommend early detection and go for a Kasai surgery than primary liver transplantation. Another case, here you can see the bilirubin is slightly high, 15, and the conjugated fraction is 12. Again, pigmented stools, but here if you look at the gamma GT is 60. The normal gamma GT for a 4-week-old baby, the normal range is 300 compared to adults. For adults, I think the reference range would be 40 to 50, but at newborn, it's around 300. That's the normal for a newborn baby, and it reaches that adult level when these babies are 9 months of age. So this, we would call it as a low gamma GT cholestasis. And it's specific for a condition called progressive familial intrahepatic cholestasis. Is this condition common in Sri Lanka? Yes, southern part of India and Sri Lanka, we see this condition quite commonly. And I think at present there are 6 types has been described. These first 4 types, FIC1 with low gamma GT, FIC2 the BSEP deficiency, low gamma GT. These first 2 types presents during infancy and childhood. FIC3 presents during, PFIC3 presents slightly older children, and PFIC4 probably in toddlers again. Again, it presents in toddlers. And you can see the first 2 has low gamma GT and the type 4 has low gamma GT, while the third one has high gamma GT. By immunostaining, the biopsy, we can confirm the diagnosis. With genetics, we can confirm the diagnosis. All these 4 types has been described in Sri Lankan children. So we have seen all these 4 types in Sri Lankan children. Type 1 and type 2 are more common. And you can see the variation. Type 1 is more of a multisystemic disease where they have failure to thrive, severe cholestasis, diarrhea, rickets, growth failure, and a lot of issues. While type 2 is more of a liver-based disease where there is no systemic involvement and the growth would be normal. And the initial management is medical, and the main problem is itching. If we can alleviate itching and the liver is not cirrhotic, uh, they can get away with medical management. But 50% of children would require transplant because with medical management they might fail. One more type of management is diversion. Here, what we do, we connect a small loop of bowel from the gallbladder so that we can make a stoma and drain it externally, or connect it to the uh, uh, transverse colon so that the bile secreted bypasses the ileocecal junction where the hepatobiliary recycling happens. So this depletes the total bile acid pool, thereby itching gets better. But if the child goes cirrhotic, then we might need to go for transplant. This is a child who had this biliary diversion. You can see how the hand hyperkeratosis changed within 2 months of time. And you can see the bile acid level has come down. This is in a group of 12 children. Coming to metabolic disease, uh, galactosemia, tyrosinemia cause cholestasis, while urea cycle defect doesn't cause cholestasis. And diagnosis is quite simple. And for galactosemia, you get the blood GAL1 put enzyme assay, and you put them on galactose-free diet. These children get well. But tyrosinemia is quite difficult to manage. Diagnosis is quite easy. Get a urine succinyl acetone. These children will have high AFP and coagulopathy. Um, I think most of you would have heard about this drug called NTBC as a treatment for tyrosinemia. What does this drug actually do? This is where the enzyme deficiency. So with this enzyme deficient, the metabolic pathway gets blocked here. You get succinyl acetone formed, which is toxic, which is carcinogenic, causes kidney, liver cancers. And this is type 2 where the enzyme block, type 3 is where this enzyme block. This drug NTBC actually is not a curative drug. It blocks the enzyme pathway slightly higher up, so this toxin is not formed. So NTBC changes your phenotype from type 1 tyrosinemia to type 3 tyrosinemia, where you still has to manage them with the tyrosine-free diet and dietetic counseling along with this drug, which is very expensive. And recently we have published a paper showing in developing countries doing liver transplantation is much more cost effective and safe. Alagille syndrome, I don't want to talk much about it. Most of you would have read about it, where you have the characteristic faces, the biopsy shows paucity. Um, and this is also a common condition which we see in day-to-day practice. The main indication for transplantation would be severe pleuritis rather than liver failure. Only few of these children go for a liver failure. Most of them will have severe cholestasis and severe pleuritis affecting the quality of life. Cystic fibrosis and alpha-1 antitrypsin, these two conditions quite common in Westerners, but South and Sri Lanka, this is not a common condition causing liver disease. Coming to giant cell hepatitis, I think you would have heard about giant cell hepatitis. Is it a benign condition? What could I do? Essentially, giant cell hepatitis is a descriptive terminology. It is not a disease. What the histopathologists say, I am seeing some giant cells. That's all. 80% of them will resolve, but 20% can be a progressive disease, and always check for Coombs positivity. The giant cell hepatitis is associated with Coombs positivity. They will have a poor prognosis requiring liver transplantation. And always beware of this mimic. I think 10 years ago, whatever giant cell hepatitis, we have been labeling them as giant cell hepatitis which failed to get better, or actually type 2 PFIC. When we try to do immunostaining in those cohorts, we find them that they are type 2 PFIC. So when you do a biopsy and you get a report as giant cell hepatitis, check the gamma GT and always make sure that you are not missing, do an immunostaining for BSEP deficiency. So what do we do for these children? I think medical management is only very symptomatic, but if they go for a synthetic failure, portal hypertension, cholangitis, uh, even severe pleuritis without any of this problem, they need transplantation. Children with successful CASI, if they have only failure to thrive, still liver transplantation could be offered. And age and weight is not a limiting criteria for liver transplantation. You can see this is a small child who had biliary atresia and had a surgery. You can see the liver is quite big. So we need to put a mesh so that the liver shrinks, and after 10 days, the abdomen can be closed, and this child is doing absolutely well. You can see how worse itching can be. So this is a child with Alagille syndrome, and you can see the scratch marks, and the child is wearing a gloves. Life is quite terrible for this child. Child can't sleep, all the time scratching. So when these children go to school, none of the children sit next to them because they constantly scratch themselves. So life is quite miserable for them. The same child after 2 months of transplant, you can see she has put on weight, happy. So this is what we do. And in conclusion, jaundice after 3 weeks is never physiological. Don't try to sort of postpone, wait, give some medicine, wait and watch. If you are worried, investigate or refer to a pediatric gastroenterologist. Always do a conjugated fraction so that even in the first 2 weeks of age you can pick up the whether the child can have liver problem. Biliary atresia is a medical emergency, so don't try to delay. It can be a potential legal case for you if you're going to miss. There are several legal cases happening now. Always see the stool yourself. HIDA is not essential and always better for an yearly referral. Hopefully, if you have this idea of these few conditions, you can actually get 90% of the cholestasis sorted. And I hope now you can see the needle quite clearly. With this, I would like to conclude my talk. Thank you very much for listening.